Thank you for inviting me, and good morning, everybody. I'm going to talk a little bit about magnetic sphincter augmentation for gastroesophageal reflux this morning. These are my disclosures, and I want to specifically thank Tom DeMeester, who has let me borrow a couple of his slides, which I think are important to understanding this presentation. This is the magnetic sphincter augmentation, or the LINX device, is a really pretty interesting story. One of the more interesting stories, actually, I've seen in my career. And it really fits a need, one can almost say, of millennials, but of our society, because although we've got good operations for reflux, they have some side effects, and people want to get better at it and avoid some of the side effects of the operation. And if you take this sort of culture of wellness and self-awareness and you put it on top of the PPI literature that's starting to come out, and people don't want to take medicine their whole life, even though it's very effective, and although the evidence is somewhat scanty about the side effects of the long-term PPIs, they do exist in a small percentage of people who take the medications. And it started off with the story about males getting osteoporosis, but I think the one that concerns a lot of my colleagues at my age is if you're taking PPIs, maybe there's an increased risk of dementia. And the study which sort of put this on the map is actually not a bad study. It's published in a very reputable journal, and what they found was that the incidence of dementia increased by 44% after being on PPIs for 7 years. And furthermore, some basic research was done which showed that mouse giving PPIs had increased amyloid deposition, and so there's a little bit of legitimate concern. And of course, once something like this gets out on the internet and everyone's reading it with various degrees of sophistication, you're off to the races. So along came Thorax, and I don't know exactly who the real inventors, investigators were, but very savvy executive team at this company, and they came up with the concept of a dynamic sphincter, magnetic sphincter device. Of course, they knew about the angel chick and they knew about the problems, and they figure that because this is dynamic and because of the properties of the material, that this won't run into the same problems. And it's really very cool. They engineered this with polarized magnets so that the force to open the magnetic ring is 28 millimeters of mercury, and of course most people's amplitude of peristalsis of esophageal contraction is at least 30. You can vomit, you don't get gas bloats theoretically, and then the mystery was how this really worked. I'm not sure that they understood it when they put it on the market, but I'll show you at least what the current thinking is of why this works. And as you can see in this photograph of one of my own cases, the magnet is not constricting the esophagus. It's not like a lap band. It sits loosely around the esophagus. And eventually there's even a CPT code now, which there wasn't initially. So how does this thing work? Really, it's designed for mild reflux, and it probably prevents reflux during inappropriate transient relaxations of the lower esophageal sphincter or with distension. So ordinarily, you know, you're sitting there, you have a relatively competent gastroesophageal valve, but when the fundus is distended, the geometry is distorted, you can reflux, and the LINX seems to prevent this from happening. At least that's the best I can explain it to you, and I'll show you that it actually does work in a second. So these guys were really very, very smart in the way they brought it out and the way they marketed it. It really is targeted, and Eric Hsu wrote a paper, our previous speaker, when he was my fellow, and I'll show you the results of this, which bears out this concept. But it's for the internet savvy, younger people, maybe some of the older people that are internet savvy too, because they're really talking about different side effects than the Nissen. There's so much bad press about gas bloats, dysphagia, problems with the Nissens. So they capitalize on that and come out with this less invasive way to treat reflux. And again, these are the same people that are reading about the PPI side effects. Now, does it actually work? When I first looked at this thing, I was like, how is this thing actually going to work if it's not a lap band? There's 3 good studies. They're prospective, they're non-randomized, non-controlled studies. Actually, some of them are controlled. But the original one was from 2012 in surgical endoscopy with 44 patients in a 4-year follow-up, and the results are really pretty interesting if you look at their Demeester scores and the time that the pH was over 4, which is what you're looking for. So highly effective. Yellow is pre-LINX, green is 4 years post-LINX. The New England Journal study by Gans, I'm going to show some more data on that in a minute, but shorter follow-up, same results, multi-center study, and then the JAX study, again, 3 years, all of them very, very consistent in terms of physiologic effectiveness. And then if you use quality of life scale, this is GERD HRQL, you can see the same effect pretty much starting at all 3 studies start at the same place, and all 3 studies confirm these GERD HRQL scores under 5, which is really outstanding. So really great work. And I mean, the quality of the clinical trials they performed to get this on the market, I think, is really first rate. It's almost unparalleled for a surgical device. And this is the New England Journal study by Gans, and you'll recognize a couple of other prominent SAGES people, Jeff Peters, Santi Horgan. This is PPI use pre-op, and what it's showing you, not only did PPI use fall to less than 20% of the people needing PPIs, but it was sustained for 3 years. Same thing if you looked at symptoms. Esophagitis generally heals if it's not too severe. The one bugaboo here is dysphagia, and now this is done with the earlier devices as they were sort of figuring it out, and actually I think if you repeated this study in 2018, this dysphagia score would improve, and that certainly was our experience at MGH et al. Now this is the paper that our prior speaker, Eric Hsu, wrote with me when he was at MGH for his fellowship in 2015, and we designed a case-matched control study looking at patients who'd had Nissens by us and patients we put LINX in. And the punchline here is LINX works in terms of heartburn. It's terrific. But we ran into a lot more dysphagia with LINX, and as I said, I think we've modified the technique in the way we measure and size it and also the dietary management, so this is much less of an issue. But the real striking thing to us was how these patients got to us. And most of them were self-referred, and once you put up on your web page that you were doing LINX, all of a sudden you were flooded with patients, most of whom frankly didn't have reflux, but a number of them did. So that's a different paradigm, I think, for surgery. Now, other people did a better job, I think, of comparing LINX to what would be the gold standard of lap Nissen, and this is a large meta-analysis from last year published in Surgical Endoscopy. They did eliminate a fair number of studies, but they had 688 patients to study, and they confirmed what we already know, that LINX is equivalent to lap Nissen in terms of reflux control. I think they came to the conclusion that the side effects, gas, bloat, and dysphagia, were the same as Nissen, but the study's underpowered. I don't think that they could make that statement. And as the manufacturers claim, that patients are better able to belch and vomit with a LINX. Okay, so, well, now there's I think the trend, certainly in Europe and starting in the United States now, is to go away from Nissen fundoplications and more back to partial fundoplications. This is a lot of the impetus for the interest in esophax and TIF and these other sort of devices which will create a partial fundoplication. So how about we compare LINX to Toupet partial fundoplication. Here's a nice study, pretty long-term follow-up really, and you're seeing the same thing here, that the GERD HRQL scores generally are falling under 5. And not only that, it is sustained. There's not really a decay here in the Toupet, and there's actually not really a decay in the LINX either. So it's durable. Here's one thing of a little bit of concern is the number of devices that have to be explanted. And here you can see the reoperations. The black line are the laparoscopic toupee fundoplications. The red line is the links, and you can see that there were a few more linxes requiring reoperation. Generally, those were explants for dysphagia. I don't know for sure whether there were erosions. I don't know the details of why those were explanted, so I really can't speak to it. Now, it's still, in many parts of the country, hard to get paid for doing a lynx procedure, in spite of all the data about efficacy and safety that's out there. And there's no question in my mind that the device is efficacious and it's safe. But what happened is when they got a CPT code, all of a sudden the volume really started to rise. And I think from an actuarial perspective, the insurers are concerned about paying for it. I really don't think it's about the data. I think it's about the money. So in conclusion, lynx is effective at controlling GERD in appropriately selected patients. The long-term safety I guess you could say it's a concern, but so far so good on that one. It's just hard to get paid if you implant it. Thank you very much.